I'm super excited to have a chat with Claude Franceschi. There can't be anybody in the phlebology world who hasn't heard of the CHIVA method, but I think certainly in the United Kingdom there are very few vein specialists who understand it fully. Well, today I'm going to remedy that by chatting to the inventor of the CHIVA method, Claude Franceschi. He's going to tell me how he became interested in lower limb venous hemodynamics, why he felt there was a need for sparing the saphenous vein, and how his understanding of vein hemodynamics in the lower limb led to the CHIVA method for sparing the saphenous vein. Claude's going to give us the background, and then he's going to take us through a presentation that he's specially made just for this meeting. Let's get started. And be sure to stay to the end, where I will give you my take about the CHIVA method and why I think that it hasn't been implemented in the United Kingdom. Thank you very much for taking part in this. It's really very kind. I've noticed that you have, over many years, been very generous with your knowledge and your teachings, and you've given it freely on various media, YouTube, LinkedIn, and other places. So I can see your teaching, and because I have had interactions with you on LinkedIn, I can see just how passionate you are about the hemodynamics of venous disease in the lower limb. And so as someone myself who's interested in lower limb venous disease, it would be a huge gap if I didn't understand the hemodynamics as you have explained in your various publications and so forth, the CHIVA method. You very kindly sent me a presentation that will form the basis of our discussion. I've watched it several times now, and you have very clearly described the hemodynamics of the lower limb as they apply to the CHIVA method.
CHIVA is a conservative and hemodynamic treatment of the venous insufficiency in outpatient settings based on advanced knowledge of hemodynamic pathophysiology. This is why knowledge of these advances is essential for the application of the CHIVA cure and the diagnosis and treatment for all forms of venous pathophysiology. EcoDoppler provided a tool that enabled this revolutionary improvement. Nevertheless, there are not yet sufficiently known and taught despite 120 articles, studies, trials, RCTs, Cochrane reviews, and 8 books. Definition of the venous function. Definitions. Venous function. There are 3 venous functions: the vital tissue drainage thanks to the transmural pressure of the venous capillary lower than the colloid osmotic gradient. 2. Adequate cardiac preload due to the reservoir effect, variability of venous volume to adapt pressures and flow to the right ventricular preload needs, and thermoregulation by superficial blood flow variation as a radiator effect. Definition of the venous system. The venous system is the set of organs that interact to produce the pressures and flows necessary to the venous function. The venous system is made of 3 alternate mechanical pumps: right heart pump, thoracic abdominal pump, valvomuscular pump, and flexible and compliant tubes, venous capillaries, venules, and veins. Definition of venous insufficiency. Venous insufficiency is the inability of the venous system to provide all or part of the venous functions. Disruption of the reservoir effect. It's a drop of the cardiac preload due to too much venous blood stored in the lower limbs while too long-standing intravenous hemorrhage, or a cava vein block lying on the back in pregnant women. Dysfunction of the radiator effect by lack of superficial veins or low superficial venous flow. Tissue drainage dysfunction, excessive transmural pressure by excessive intravenous pressure or low extravenous pressure. Practically, transmural pressure here is the only cause of edema, varices, traffic disorders, and ulcer. Transmural pressure is the pressure difference between intra and extravenous pressure responsible for edema, varicose veins, traffic disorder, ulcers. So, transmural pressure results from intravenous pressure opposition with extravenous pressure. Intravenous pressure is hydrostatic pressure, residual pressure, muscular pump pressure, and extravenous pressure is atmospheric pressure, tissue pressure. The result is transmural pressure. The intravenous pressure is the sum of gravitational hydrostatic pressure and motive pressure. Gravitational hydrostatic pressure depends on the posture. Motive pressure is the sum of residual pressure fed by the heart through the microcirculation, thoracoabdominal pressure when breathing, and valvomuscular pressure when walking. Extravenous pressure opposes the intravenous pressure. It depends on surrounding tissue pressure and atmospheric pressure that decreases with altitude. Tissue pressure, atmospheric pressure. The venous caliber depends on transmural pressure, compliance, viscoelasticity, and vasomotricity and media thickness. Tissue drainage. The interstitial fluids of the tissue are drained into the venous capillaries when the colloid osmotic pressure gradient is greater than the transmural pressure at the level of the microcirculation. Control of the transmural pressure by gravitational hydrostatic pressure, residual pressure, extravenous pressure. The gravitational hydrostatic pressure varies with the posture at rest and increases when walking due to my proposed concept of dynamic fractioning of gravitational hydrostatic pressure, DFGHSP. Normally, the dynamic fractioning of the great hydrostatic pressure decreases the pressure when walking from 90 millimeters of mercury down to 30 millimeters. In case of valve incompetence impairs the dynamic fractioning of the great saphenous pressure here, but it doesn't change it at rest here and here. The residual pressure provided by the arterial pressure through the microcirculation increases with the obstacles to the flow as stenosis and occlusions. When the obstacle is total, the flow is blocked and the pressure reaches the arterial values. Remember the phlegmasia cerulea. Obstacle to the flow increases both residual and valvomuscular pump pressure, explaining venous claudication and explaining also the excess of pressure at rest. Some venous obstacles are artifactual because postural, as many nutcracker and Maternus syndromes, stenosis, only in supine posture and over-treated due to the venography and Doppler performed in artifactual supine position. Pseudo-Maternus syndrome is total occlusion on supine but free on semi-sitting position. Supine, total occlusion, stop of the venous flow. Semi-seated, here, the flow is liberated and free. In 1988, I proposed a systematization of venous networks, N1 for deep veins, N2 for the trunk of the Saphenous and Giacometti veins in an aponeurotic duplication, N3 for the supra-aponeurotic veins and the physiological drainage hierarchy, N3, N2, N1. And then I define the pelvic escape points. Venous networks, regardless of the direction of the flow, antegrade or reflux, the venous flows remain physiological if they do not reverse the drainage hierarchy. For example, CHIVA does not ablate the reflex direction, but restores the physiological drainage hierarchy, which normalizes the flow rate and the pressure. In 1988, I described the veno-venous shunts responsible for the hierarchy reversal of the drainage. They are overloaded through escape points, N1 and 2, N2 and 3, N2 and 1, and drained back through the reentry points, N2 and 1, and 3 and 1, according to the anatomical configuration. This is escape point N1, N2, N2 and 3, and N1 and 3. In this example, this venous closed shunt, due to a valve incompetence of the great saphenous vein, great saphenous vein is overloaded by the flow rate and pressure of the femoral vein during the diastole of the calf valvomuscular pump, which reverses the hierarchy through saphenofemoral escape point, EP, and redirects it back through the tibial reentry point, RP, escape point, reentry point, during the diastole of the calf. The flow of the femoral vein is aspirated here through the escape point and the reentry point, escape point, reentry point, escape point, overloading the flow of the great saphenous vein. In this other example, this is a veno-venous open vicarious shunt due to a femoral vein thrombosis. Great saphenous vein is overloaded by the flow rate and pressure of the popliteal vein during the systole of the calf pump, valvomuscular pump, which reverses the hierarchy through the tibial escape point, EP, and redirects back through the saphenofemoral reentry point. The thrombosis of the femoral vein. This is an escape point from the popliteal vein through a tibial perforator, for example, and that without any reversed direction, but direct direction, there is an overload of the great saphenous vein here with the reentry back in the common femoral vein. Various types of shunt are classified according to their escape points, reentry points, systolic and diastolic, and their activation by the Parana or Valsalva maneuver. Thanks to echodoppler, I could describe anatomically and hemodynamically the so far not defined pelvic leak points: perineal point, obturator point, inguinal point, clitoridian point, inferior point, superior gluteal point. This is various closed shunts from shunt 0 and various shunts of shunt 1, shunt 2, shunt 1 plus 2, shunt 3, various shunt 3, shunt 4, shunt 5, shunt 6, and mixed shunts. I don't describe precisely here. It will be described by the other lectures. The usual escape points are the saphenofemoral junction, the saphenopopliteal junction, pelvic escape points, 10 points, various perforators here, and N2 and 3 junctions here, like here, like here, like here. I proposed Doppler reflex rate classification, the dynamic reflex index, with from normal to partial, segmental, total reflex, and closed shunt reflex. Whatever the etiology of the venous insufficiency, it creates obstacles that increase the result pressure and/or creates the venous incompetence that increase gravitational hydrostatic pressure, and shunts that divert the valvomuscular pressure. All these cause and effects create an hemodynamic disorder, which is excess of transmural pressure. Whatever the etiology, the manifestation, the clinical manifestations are drainage impairment by edema, hypodermic ulcer, and venous dilation by varicose veins. Once again, edema, varicose vein, trophic disorders, ulcer have one cause, an excess of transmural pressure. The physiological hemodynamic treatments must, whatever the cause, lower the transmural pressure according to the cause: obstacles, liberation, stent bypass, valve incompetence, valve repair, artificial valve, CHIVA strategy for superficial and deep venous incompetence, and posture to decrease the gravitational hydrostatic intravenous pressure, or compression to increase external pressure. So any treatment that reduces the TMP excess is an hemodynamic treatment by intravenous pressure reduction like elevation and CHIVA, or extravenous pressure reduction like compression. Any venous obstacle causes an excess of residual pressure responsible for all the signs of the venous insufficiency. Superficial veins ablation provide good immediate results, but mid-long-term damage as new compensatory varicose veins and spider veins. As it preserves the veins, so the draining flow, CHIVA, prevents recurrence and drainage impairment, and at the same time saves the great saphenous vein for a potential need of vital arterial bypass. A good pre-CHIVA test is the Perforators maneuver at the escape point that collapses to normal the varicose vein because it is no more overloaded by the closed shunts before after walking. The basic principles of the strategy are the venous shunt disconnection, the saphenous vein sparing, the blood pressure column segmentation or fractionation, reentry perforator spare, non-draining L3 and L4 or N3 or N4 ablation. This is an example of CHIVA from before the operation, at the end of the operation, no more visible varicose vein. They say this was the cartography or the mapping before the operation, and this is the strategy of the disconnection of escape points. The technical principles of the CHIVA tactics are local anesthesia, ligation and division only with non-absorbable suture, disconnection flush the escape point, no stamp left behind, N2 N1 disconnection, division or triple N3 thread ligation flush the great saphenous vein femoral junction, and flush the small saphenous vein Giacomini junction. N3 N2 disconnection flush N2 plus 2 to 4 centimeters resection, 6 non-draining L3 and L4 ablations. These scientific contributions to echo Doppler and venous pathophysiology place the author among the 50 key figures of the Vascular Origins book. The cause of the venous ulcer is only the excess of transmural pressure at the level of the microcirculation. All the clinical signs are not cause but complications, inflammation, infection, necrosis. The proper treatment is reducing the transmural pressure by venous ulcer hemodynamic bandaging plus antiseptic management with 2 hours elevation with light elastic compression to deflate edema, deflate like that, no debridement, just cleaning, and apply Vaseline 40%, icing sugar 60% mixture, non-elastic bandaging, and Doppler check of the distal arterial flow. Conclusion. First, think TMP, whatever the sign, symptoms, and especially CIP. Then assess and treat hemodynamically the shunts, respecting the drainage. Ablation is an irrational approach. It consists in vein ablation, phlebectomy, sclerosis, laser, radiofrequency, because it impairs the drainage and leads to residual pressure excess with tissue suffering, varicose recurrence, and destroys the venous capital. No more great saphenous vein for a vital arterial bypass. Instead of the hemodynamic approach, which is rational, consists in TMP reduction by extravenous pressure increase, leg compression, intravenous pressure decrease, feet elevation, block liberation, and CHIVA, which is hydrostatic pressure fragmentation, shunt disconnection, drainage respect, and venous capital conservation. Thank you and congratulations for your patience.
The CHIVA method now is what, 36 years old?
Well, up to now, maybe 35, 36 years. No, 40 years. But you know, at the beginning, my work was vascular, and I was interested in arteries, not in veins, because veins only for thrombosis, phlebitis, but not varicose veins, because for me it was a benign disease. And I was more interested in arteriopathy and carotid and so on. At this moment, before I developed and studied Doppler as semiology, and I wrote the first book on Doppler, but for arteries. But not every day, but every week,
Yes.
in our department, we had problems with patients with acute arteritis, ischemia, and so on. And well, the problem was we needed a saphenous vein, and too many of them didn't have any more saphenous vein because before stripping, they had sclerosis and so on. So I said, well, I tried to treat this varicose vein without and saving the saphenous vein, because you never know if you need it tomorrow. Maybe you have an accident, you have a rupture of the popliteal arteries, and so well, it could be save life, really. And at this moment, but for that, I had to understand venous pathophysiology. And all I wrote, I didn't understand anything because there was no rational, you know? It's just, well, this says you cut it out, okay? Well, okay, with the ischemia, acute ischemia of lower limbs, you cut the foot, you know, but it was not stupid, but not enough at all. And because from the beginning, this pathology interested dermatologists, and dermatologists want to clear out everything, you know, without thinking the meaning of the vein. And I said, but it's stupid because when you elevate the leg of a patient varicose vein, you don't see anymore the varicose veins. So it's a matter of pressure. He said it's a matter of pressure. I will try to make so that when the patient is standing, it's just like if he had the foot elevated. You know what I mean? Is my English clear for that? It was stupid. So I studied, and thanks to Echo Doppler, because for the first time at this moment, I had the patented device to add to the probe of echograph, because at this moment, echographies didn't show you arteries and superficial vessels. And I patented this, and with this, I could see better the vein arteries, carotid, and so on. And from this moment, I thought I had to revisit the functional anatomy of veins and the physiology and physiopathology. And from this, thanks to Echo Doppler, I could see what nobody saw before me. You know what I mean? Because you use your hands, you don't see enough. And I had the idea of the networks of the venous system, and the function and the shunts are the basic pathology of the varicose vein. And my idea is the vein is not There is no disease of the vein. Just the vein is victim of something. What is something? It's excess of pressure and flow. So treatment, I wanted to treat the vein by reducing the flow and the pressure. But before me, one century before, Perthes and Trendelenburg has shown this. When you see Perthes, you put a ligation, a tourniquet on the leg, and to make the patient walk, and the varicose vein disappear, shrink totally. They did it, but they were the last doctors to think hemodynamics. Afterwards, with stripping, they forgot hemodynamics for more or less one century. For example, if you want to know what will happen when you will perform a CHIVA to a patient, you have your strategy. You have assessed it with echo Doppler and so on, and you have made a mapping, and you say, I just go there, I disconnect this shunt and here. And before operation, you put a tourniquet at this point, and you ask the patient to walk. He walks 10 steps, and all disappear. And he sees what he could wait from the operation. And you see also this, for example. So there is something new. What is new is just a revival of an hemodynamic approach of the 19th century. So just that. And the basics of the hemodynamics are not so difficult to understand. But, but the doctor must study hemodynamics. They can't understand it without studying it. But because they are not used to. But if you explain CHIVA to a plumber, he understands 5 minutes. To a physicist, they understand at the moment, And why not a doctor? And they are supposed to be a specialist, so to know the pathophysiology of what you are supposed to treat. We don't ask a dermatologist to know and understand hemodynamics, but vascular specialist, it would be basics. But it's just the fault of teaching universities. They don't teach because the professor don't know.
You must be very frustrated when you see that there's a lack of enthusiasm for the CHIVA method. To be clear and to be honest, in the United Kingdom, it is not a treatment that is practiced. In fact, I don't know anyone in the United Kingdom who does CHIVA. There may be some, but I don't know them. Do you know? You may know. Do you know anybody in the United Kingdom who practices CHIVA?
No one. No, I am not frustrated. It's not my problem. If you don't do something, I think it's a good thing. Well, I explain you. If you don't do it, I am Democrat, You do whatever you want. But I have informed you. In my ethic, my knowledge does not belong to me. It's not my property. My knowledge comes from all the surrounding, all other doctors, history of medicine and so on. So it can't belong just to me. It belongs to everybody. And but we have very good centers, CHIVA centers in China, in Germany, in Italy, Spain. For example, in Spain, the registry showed that the majority of operations are CHIVA in Spain. Okay, for example, South America, some in Brazil, in Venezuela, in Colombia, for example. No, but not in USA and not in Great Britain.
That's very interesting. I don't know why we don't know about it in the United Kingdom. Do you have any idea why there is lack of interest or lack of knowledge in the United Kingdom and perhaps even North America?
We have many explanations. First of one, it is not English. It is not English. So, well, just a moment. They are just, froggy people, are not important for them. Secondly, it's easier. Anglo-Saxons are conformists, are open but conformist. And the conformists make people very conformist, and it's not easy for them to change their mind and to open their mind abroad, but where they are. But this is in every country, but more or less. But maybe it's more. I have very many friends, English, British friends, very close, really brothers. But it's not my problem. It's maybe this problem. In France, for example, in France, they are arrogant. There is in the culture, it's arrogance and jealousy. So they don't like that one of them is better than the others. So they try to kill him before, But with time, 2, 3, the generation, it grows up with time. For example, when I have explained the Doppler, vascular Doppler, I wrote the first book in the world of semiology, but up to this period, nobody did understand what to do with this, just to measure the pressure at the ankle and more. So I explained how to diagnose stenosis, carotid, and so on. But it took 20 years to be accepted. For 20 years, they told you, well, that's not true. It's But I had so many pupils at this moment, and now it's a banality. Everybody used this semiology, but it was rejected for 20 years. If humanity was good, maybe world would be different. But you have to manage with it.
Do you recognize the problem of incompetent perforators? It seems to me that the CHIVA method is about reentry points with perforators.
But
do you perceive a problem with incompetent perforators, and how would you deal with them?
First of all, a perforator is a communication from deep to superficial veins. Whether it's draining, the flow is from superficial into deep, or it's refluxing against the hierarchy physiologically from deep to superficial. And you have these communications are on with or without competent valves. If you call incompetent a perforator with destroyed valves or no valve, it is incompetent, but not necessarily refluxing, because the direction of the flow depends on the pressure gradient from superficial to deep or to deep to superficial. So reentry is when whatever the competence of the valves of the perforator, whatever its caliber, is during the diastole of the muscle, of the muscular pump, during the diastole, you have the flow in. At the moment, it's a reentry. If you have the flow out, it's an escape point. And and from time to time, you have an escape point during the diastole. Okay? During the systole, it's not a problem because it's just more or less compensatory. And it doesn't provide any problem of pathology. It's the diastolic one. When your muscles are in dilatation. At this moment, well, so in my experience, I have found so many patients, and very few have a reflexing perforator below the knee. Most of the time, 99% of cases, it's a reentry. But many surgeons think, oh, I have to close it and so on. Because they are wrong, completely wrong. And for me, the bigger the reentry, the best the result, because it's a reentry of a closed shunt. If you disconnect the shunt, it shrinks totally the saphenous veins, for example, or the varicose vein, and the reentry is fantastic. That's the point. So, and the reflex during the systole, most of the time, it's tiny and not important at all. And in any case, sometimes it's a compensatory of some deep block. At this moment, you have not to close it because it's a compensatory flow. And three, the difference with the pelvic link, the pelvic point I described some years ago. I described 5 leak points from the pelvis, you know? And this is, whatever you do, the flow of these veins is all the time up, down. And you can't know if it's a reflex deep to superficial or not. The only way is, for example, to perform Valsalva, because compression relax is positive every time, and you can make the difference between them. So that's why you have to, doctors and colleagues have to learn and study. Otherwise, it's impossible. Did I answer? Yeah. Hey, Wyndham. Bye. Have a good day.
So there you are. There's no doubt that Claude Franceschi has really pioneered our understanding of lower limb venous hemodynamics, and he's applied it in a systematic and methodical way to improving the hemodynamics and improving the outcome for patients. But why hasn't it been adopted? Well, I think one of the reasons is that it is full of scary equations, which some vascular surgeons don't understand. Vascular surgeons, certainly in the United Kingdom, are used to ablating the saphenous vein. After all, we're used to doing a high tie and strip of the saphenous vein, or at least a ligation. And so other methods such as laser, radiofrequency, glue, and even ultrasound-guided foam sclerotherapy continue that tradition of vein ablation. And so the idea of preserving the saphenous vein is somewhat alien to vascular surgeons, who are predominantly those who provide vein treatments. The second reason is that some of the concepts are a little bit difficult. For example, there are 12 shunts that have been described, all with a different pattern of reflux, pathways, and re-entry points. That can be daunting. The crisis in vein care in the United Kingdom, it's hard to see how CHIVA could be rolled out and scaled for the daunting number of people who need treatment. With increasing nurse-led clinics, it's hard to see how the CHIVA method could be applied to that. Nevertheless, I think all of us who are involved in vein care need to have a basic understanding of the CHIVA method, and certainly need to have an understanding of venous hemodynamics. I've put links to all of Claude's resources. There's a link also to his YouTube channel. Follow the discussion on LinkedIn, and don't forget to subscribe. And that way, you'll be amongst the first to see my next video. Thank you for watching.